2 Wednesday nights ago, what call did we have? Who wants to do the dispatch? Jackie, were you up to?
Yeah, I think we had an 8-month-old baby and most would say 106 weeks.
Okay, so our dispatch, I don't know if everybody heard Zach, but it was about, 20 after 12 on that Wednesday night. Dispatch was, 53 standby, 106 fever. I think they said baby with a 106 fever. Baby turned out to be, a year and a half old. And she did indeed have a fever. Her mother initially reported to us at 106.7. So does that do anything to anybody? Does it bother you? All right, so what, it does? Yeah, it does. Why? Oh, come on. Really?
It's high.
Okay, so it's high. 106.7, I think that's a radio station, isn't it? All right, so the point is, what bothers you about that 106?
Seizures. It's
Okay, seizures. All right, is everybody kind of thinking along those same lines? Is that what bothers you? What if I told you I'm not bothered by that? Okay, you want to know why? So that's what I'm going to tell you, why. All right, so in order to do that, let's talk a little bit about the febrile response. So we're going to start just physiologically, actually a little bit too in terms of definition. What we're really dealing with is hypothermia. So you've got an elevated body temperature. There is a distinction, however, between febrile illness and hyperthermia, even though, fever is a part or a subcategory under hypothermia. The interesting thing about fever is that it really is a well-organized, well-orchestrated host response. Mother Nature is in charge of this. And if it's true fever, Mother Nature's not going to really allow that body temperature to exceed that 106. So I'm not talking about 106.2 or 3 or something, but, in that range. The range is about 105.5 to 106. And we've learned a lot over the years about the benefits of fever, and I'm going to convince you that fever is a friend, not an enemy, not the enemy that you think it is. So we say highly structured, well-organized, well-orchestrated host response. What happens is that your body is invaded by microorganisms, and it sets off a series of changes. All kinds of things are produced. The bottom line is something like endogenous pyrogen is ingested, and it releases all these cytokines and all these things. Bottom line is a substance called prostaglandin is produced. And what prostaglandin does is it turns up your thermostat in the hypothalamus. That's your temperature regulating center. And think about it in terms of the oil burner right now. So what happens, you walk into the house, it's cold, you're going to set it up to 70. Well, what does your oil burner do, assuming that the in-house temperature is 64? So the oil burner is set up at 70, and what does it do? It kicks on. And what does it do? It generates heat. All right, so your thermostat, which is ordinarily set at 98.6 because that's what we say normal is. So with all these changes ultimately resulting in the production of prostaglandin, the thermostat goes from 98.6 and in this baby went to 106. So what happened? In order for the baby to achieve that body temperature of 106, the baby goes into a state of hypermetabolism. And how can we tell? Think about it when you're sick. What's the first thing that happens? You get the chills. So what in fact are the chills, or these muscle fasciculations, or rigors? What's the byproduct of all these muscle fasciculations? Energy and heat. So the baby will continue to generate heat until when? When does your oil burner shut off? At 70, right? Because isn't that we set the set point at? All right, so when does this baby's body temperature stop? Well, at 106, if that's what the set point was elevated to. So as I said, it's still well controlled and well orchestrated. Yes, the 106 may bother us a little bit just because it is unusually high. The average kid's going to run in the 104 range, probably 105, but 106 is kind of is kind of up there. All right, so that's what your true fever is, and we'll do a little bit more with that. Now look at heat illness. So heat illness, that's the true pediatric emergency, because that's that child that is in the back seat, in the car seat. It is July 4th weekend, and where's the mother? In the cheese shop. All right, kids sleeping, it's 110 degrees. How hot is the ambient temperature in that car? It's very hot. So tell me though about the baby's set point. This baby's not sick, so the set point is still, what's normal? 98.6. Oh, but if I take that baby's temperature, measure it, I might get 107. I might get 108. Why? Mother Nature is not in charge. And that baby can't dissipate that heat fast enough. She can't sweat it all out to keep bringing her body temperature down. So the environment is in charge here, and that's where the danger lies. So this is, using it in quotes, this is what fries your brain and ultimately destroys multiple other organ systems as a result of this. So here's our big difference. So in a sense, I'm really not afraid of fever because I know Mother Nature is in charge, and she's really not going to let anything bad happen, to this baby, if you think about it, all right? Let's see if this will go forward. Maybe get my button out. Just this thing. All right, so the other one, this is something that you won't see, but under that category of hyperthermia, this is something called malignant hyperthermia. Very interesting phenomenon. It's actually something that's genetic and something that you kind of inherit, and it really is related to the halogenated anesthetic agents. So it's an untoward response to certain medications, in particular these anesthetic agents. And what happens here is the child undergoing surgery, as anesthesia is being delivered, it brings changes about in the body, and the body temperature just shoots way up. So again, it's something that's genetic and it's predisposed, and you have no idea it's going to happen. Usually the anesthesiologist, they start noticing this child with the rigors and the body temperature shoots up, they have to stop the case and go forward. We have an antidote though for malignant hyperthermia in the terms of a drug called dantrolene. So we can really bring that body temperature down, because that's another one. Dangerous? Yes, because why? Mother Nature's not in charge. So you've got true fever, which really falls under the definition of hyperthermia, but once again, doesn't really carry the same significance as heat illness and malignant hyperthermia. Okay? All right. I kind of alluded to this. It's not anything that you need to remember, but once again, in terms of fever, there's all kinds of things that do take place, and that causes that set point to be elevated, and then the baby is going to start shivering to generate heat so that they can get up to the set point. Thermoregulation does take place in that anterior hypothalamus. And it's kind of interesting. There's some interesting observations that you will probably make. I don't know if, Zach, you touched her extremity. She's kind of, with a little bit of humor, there was some anxiety. That's probably an understatement, wouldn't you agree, Crew? Detective Murphy was in the house first, and then I got there right before you because it was close to where I live. And the mother was holding the baby, this 1.5-year-old, gorgeous, curly-haired, little pink cheeks, screaming child. Well, I'm reassured. Why? What do you know about a screaming child? That's our healthy child. We like that screaming child. If she was holding this kid, just limp and obtunded, then I would be profoundly tachycardic at this point. Okay? Really, right? Because what do we know? So here is this mom is holding the child, and it was like, I don't know, Zach, if you felt the same way. I swear we had like chase the mother. She's like, my purse is over here, my husband, he said the Ranger game, and I'm trying to, and I'm taking the diaper bag, and she says to Murphy, can you go get the, I mean, it was like this flurry of anxiety, and it was like, wanted to really try to catch her and sit her down, you know, and we didn't quite do this. So, but that's what fever can really do, and generate that. So the wonderful thing was, kids screaming, didn't look good, so it's kind of like, all right, we can step back, but again, generating a lot of anxiety. But my point being too, though, if we really could touch her, if you're using the back of your hand and the forehead, or I usually do the core, which is right above the belly button, you really can't use the hands or the feet. Does anybody want to take a guess? So as this baby is shivering to raise her body temperature, what does Mother Nature do? Well, she wants you to raise your temperature, so what is she going to do? Where's she going to direct blood flow? To the core of the body. So you go touch a febrile child, and their extremities are cold. We used to see the mothers coming in the office or the emergency room with a febrile child wrapped in 37 blankets, because the perception is the baby's cold. And there's a very interesting phenomenon on your part too. You get the chills. We call this volitional activity related to the febrile response. You get the chills, right? You're on the couch. What do you reach for? A blanket. Don't you snuggle underneath it? So what are you in fact doing? You're actually trying to conserve heat. Mother Nature's telling you cover yourself up. Conserve heat because we want to raise your body temperature to the 103.6 that your set point is at. So that's kind of what happens. So she's going to conserve heat. Okay, so the mother actually did give some Advil about 10 minutes before we arrived. Advil's a wonderful drug, especially when the fever does exceed the 102.6 kind of range. It will really begin to bring that fever down in about 20 minutes. And as a matter of fact, what was the temp when we left? It was 105. Okay, so in the 20, how long were we really on scene once we could catch the mother and get the kid, going? We could, the temp was actually down to about 105, and they decided to, transport, that's another decision, but what happens? So, all right, so you take ibuprofen, or acetaminophen, which is Tylenol, ibuprofen, Advil, or Motrin. So we give that dose for fever management. What does it do? The interesting thing about that is it blocks the production of prostaglandin. So then it will lower the set point. So in our baby, for example, maybe that dose of ibuprofen is going to reduce the set point to 103. And then what will the baby do? What do you do when your fever breaks? We use that. You start to sweat, right? You take off that blanket or you kick it off. So that's when, you defervesce and your body temperature is going to start to come down. Now, the mother did say something. I don't know if Dr. Farley actually heard that. She said something about ice packs. Okay, so what do you think about ice packs if we choose to manage fever? They'll buy you just a little bit. Somebody talks about, a tepid bath. Well, that'll buy you maybe a degree. But the thing is, your drug of choice has to be acetaminophen or ibuprofen. That is the only thing in fever management that brings down the set point. So putting the kid in the tub, packing him in ice, only just changes the environment. The minute you stop that, take the kid out of the tub, take the ice packs off, what happens to the kid if the set point's still 106? And up goes the body temperature again. So it's not going to really be, effective in managing the kid. All right, so what else do we want to say? All right, so a little bit, all you need to know about thermoregulation in 4 sentences. All right. I always like to have just a little bit of fun, especially the mothers in the room. Clinical thermometry, that does that. Marilyn did. We got to get the ear or the nose scan. We wanted to take a temp in the ambulance, and you can't do it with the thermometer that we have. It's, So anyway, we talked about that, but I like to have a little bit of fun, especially for the parents in the room. How do we really take it? What do you remember? What's supposed to be the most accurate method of assessing body temperature? Anybody want to take a guess? Rectal temps. Okay. I always like to have a little fun with this. All right? Okay, so in the late 1700s, okay, about 1780, something like that, Carl August Reinhold Wanderlicht took 1 million temperatures. Okay? So he took about 1 million temperatures, none of whom, by the way, were children. All right? And what did he find out? He found out that the average normal body temperature was 98.6. Okay. So yet we have a discussion about the accuracy and what's the most accurate. We've always thought in the medical world that rectal temps, were the most accurate. Does anybody want to take a guess as to how Carl August Reinhold Wanderlicht measured body temperature? Axillary. And the gold standard. Okay? People don't even know this. But anyway, so I thought you needed that bit of trivia. Okay, so under your armpit. That's how we measure it. So that created our gold, so that created our 98.6. I'm really interested in fever and have been in a long time. The interesting thing is it's the 98.6 that needs to be studied because that's probably not the norm. Yeah.
So is it different rectally?
Yes.
Is
Your
it,
body temperature is not the same in all areas of the body, okay? So when clinical thermometry changed, when we went to the ear thermometer, there was a lot of discussion about, they're grossly inaccurate, how can you really measure the temperature in the ear? That's not really going to work, and people really doubted it, and everybody's still back on, no, rectal temps, they're the most accurate. Well, back in 1979, there was a book published by Martin Loring called The Febrile Child. Do you know what he said back in 1979? Rectal temps are higher than core. What lives in your gut? What do bacteria do? Create energy. What's a byproduct of energy production? Heat. So he told us back in the late 70s that rectal temps are probably higher than core. And where is the core? That's the other big argument today. Where's the core? Actually, the core is the temperature of the blood leaving the heart. Well, we can't drop an esophageal probe and measure your temp where the blood leaves the heart, right? We can't do that. Okay? So what is the next best thing? And that's where tympanic membrane scanning came into being, because what that does is it measures the temperature of the blood circulating around the eardrum. Well, that's very close to your hypothalamus, okay? And that's your temperature regulating center. So the argument about clinical thermometry, it really has been kind of fun. My own opinion, it doesn't matter. As long as you use one system, you want to compare apples and oranges. So it's all about the trend. It's not about the number. I prefer, with a little bit of humor, I like the old fever strips. They are grossly inaccurate. Okay, so why do I like them? Because they just say 101, 102, 103. It puts you in a zone. I don't really care about a number. But what do you want to really know over time? What's the trend? Did the Tylenol or the Motrin work? Is it coming down? What's the zone? So it's not just the number. And the problem today, and you reacted to that 106, the problem today is you look at fever as just one parameter. What's the other parameter? You look at the child. And we had a screaming, cute little active baby. All right, so also back in the 80s, there was something, they called it the Yale scale, or the Acuity of Illness Observation scale, that was produced. So this is after a lot of Martin Loren's work about fever, friend or foe. This scale comes out, and actually the fever, the body temperature is on it, But then you start looking at behavior, level of consciousness, level of hydration, the child's interaction, recognition of the mother. So there were these other characteristics. And this is another very interesting thing. Remember, I'm big, we talk about in the MT class on assessment and using your senses, your eyes, in addition to all the magic numbers. But your senses are the best things when you're looking at the child. So Dr. McCarthy et al., this whole group up at Yale, when they were studying fever and came out with this acuity of illness observation scale, he said, this is very interesting, in the presence of fever, the baby who smiles is not sick. All right? So the next time Zach goes to that house, you're going to make that baby smile. Right? We don't care what the fever is. That baby smiles, what does it tell you? Now I can give you, but the converse is true. In the presence of fever, the baby who does not smile is sick. So the point being, it's about interaction and looking at the kid's behavior. And that's why I said to you at the beginning, I'm not cavalier. I came across a little bit like that, but I really wasn't that worried once I saw a screaming baby. All right? So a little bit too about the numbers, the magic numbers, and looking at the child in addition to the number and how we take, that was just about, discussion about, clinical thermometry. All right, so who believes me when I say fever is a friend? Want to hear some other little tidbits before we get to say, yeah, okay, fever is a friend. Has all kinds of good things. So your body temperature goes up. You know what happens? Organisms are heat sensitive. Okay, so what is Mother Nature doing? She's going to try to knock off a couple of these organisms, whatever is the offending organism. It also enhances the production of white blood cells, which are involved in fighting off disease. There's a gazillion other little things that, fever will do. Survival of organisms, I actually just said. And we had some very interesting studies. If you take something very primitive like a goldfish, and the goldfish gets its goldfish flu, what the goldfish does is goes to the warmest part of the tank to try to warm itself up, because it has no ability. And the little goldfish who's prevented from going to the warmest part of the tank is going to not survive. All right, we've got one of the best human studies was done on 2,000 kids with measles. So what they did is part of the natural course of disease of measles, kids run fever. So they left 1,000 kids just run the fever, and they didn't treat them with Tylenol or ibuprofen, Motrin. Then they took the other 1,000 kids and they treated them. Now measles is not a benign disease. It's got some very severe complications. In which group? Because you know the answer. But in which group were there more complications of measles? More pneumonia, more cerebral ataxia. In the group whose fevers were treated. So the thought today is our very aggressive management of fever is prolonging illness in these kids. So we don't have to be as aggressive, all right? So we know about fever being a friend. Now, with all due respect, what about fever the enemy? Is there a point at which fever can become the enemy? All right, so we're going to take a guess. Yes, the hypermetabolic state. How comfortable is it when you're getting It's not very comfortable, okay? All right, so the discomfort that goes along with that, and just being uncomfortable. When your body temperature exceeds 103-ish, you generally get those body aches. You get a headache. You get a little somnolent. That's actually part of fever, not necessarily the disease that you have, e.g. flu, okay? And then, of course, the other component is the febrile seizure. And that's where fever phobia comes into play here. We have a generation that has and continues to have what the experts will call fever phobia. So what does that mean? That's the term was, Dr. Barton Schmidt out of Colorado. He termed fever phobia. So we're all afraid of fever because everybody says fever, and what happens? You seize. Okay, not true. All right. So let's talk about the febrile seizure. Again, they're respectful because yes, it can happen. Oh, let's jump ahead. Okay. What happens, what we know today, to reassure us, this is a normal phenomenon of childhood. Okay, it is considered normal. The neurologist will not see a child until they've had a second febrile seizure. So that's what we think today, all right? Statistically, it's approximately 3 to 5% of all the children are at risk for a febrile seizure, 3 to 5%. That's the same risk for urinary tract infection. Okay, it's not very high, but about 3 to 5%, okay? We also know there is zero morbidity, mortality associated with a febrile seizure. No sequela, no complications, okay? So that's a little bit of, certainly good news. So what do we know about the why? What really generates this? Why do these kids seize? Well, some people, I'll take a guess. If I say, what do you think? If I say, yeah, what causes that febrile seizure, Carla?
A jump in temperature spike.
Okay, a jump of the temperature spike in a short period of time. Anybody else? On that right track? Yeah.
Could it be either direction, going up or down?
Could be either direction going up or down.
Trying to
Any thoughts?
control the fever with medication.
Controlling it, say, with medication. Well, let me tell you about the pathophysiology of what we know today. Each and every one of us has a seizure threshold. Hopefully it's all up in the clouds. Our seizure threshold is up here. But in that 3 to 5% of children, during the initiation of the hypermetabolic state, right? Okay, during the initiation of the hypermetabolic state, Carly on that right track, when that fever starts to go up, your seizure threshold starts to come down. The baby will seize wherever they cross, not associated with a number. So some kids seize at 99, some kids at 100, 101, 2, 3, 4, or 5 or 6. The other thing was, in that house with that child, that kid was already 106. What did I know? Kid's not going to seize. Why? Already up there. She would have seized before. Okay, I would have been more worried if the kid was a little bit more miserable, lethargic, the temp maybe around, the mother says, oh, I just took it 15 minutes ago, it was 103, now it's 105, it had got maybe to 106, so, during the climb. Not necessarily the rapidity, but it is during the initiation of that hypermetabolic state that changes the seizure threshold, okay? Bringing the body temperature down, how fast you bring it down is not associated with the fever. The other good news about our kids is that the child will only seize once during this particular febrile illness. So in other words, if you bring that fever down, and it does spike back up, what's your risk? Is a zero risk. You don't seize. And even biphasic diseases, if your fever was up and then it comes down and it stays down for a couple of days and it goes back up, no. That's the same febrile illness. It's usually just one seizure with that febrile illness. So as I said, the good news is you get a kid who's up there at 104, 105. Then you're really not worried. You would have seized before. Okay? What else about our febrile seizures? Yeah.
So, we have a call to a febrile seizure, and there is zero chance that that kid's gonna seize again?
Right. Yeah. Once they recover from that, once it's self-resolved, the risk of having a second seizure during that whole illness, let alone right while in front of you, is virtually non-existent. Okay, so it's one seizure in one febrile illness. So let me give you some other better statistics too about febrile seizures. If the child has had one febrile seizure and is under the age of roughly 1-ish, that child does have remember we talked 3 to 5%, that kid though who's had a febrile seizure, so this becomes important in the history, the risk for another one in another febrile illness goes to 40%. And then the risk from a second to third stays at 40%. Okay, so the younger the child, the earlier the febrile seizure, the risk is jumping ahead from 35% up to 40%. All right? So there is that risk. There also, in the history, it's always important for the EMT to ask, do any of you, the parents, has anybody had febrile seizures as a child? There's kind of a familial tendency there as well, you know. Okay. What else do I want to say about that? So, you know, in essence, it's kind of we consider it benign, but we're not going to underscore that because it is probably the most frightening thing the parent will go through. It is absolutely terrifying to be totally unprepared and to see this child, you know, seize. And I think I've said it when we do the PEDS class and talk about it before, most of the time when we hear that dispatch, baby not breathing, my first thought is this is not a baby who respiratory arrested, this is a baby who seized, and by the time we got there, be a little postictal. And most of the time that baby is seizing as a result of this febrile illness, okay? Now, the mother did manage it. This doesn't mean because this kid's temp is 104, 105, we're not really going to manage. Even though we know fever's a friend and less than an enemy, you know, we still manage it. So what, you know, we can make the decision. And in clinical practice today, not associated really, we'll take a group out of there for just a minute. But you can make a decision as a parent, for example, you know, not to treat. If I have an 8-month-old sitting right here who has a 101 fever, but that kid's not eating, not drinking, and has the blahs, and I have another kid over here with a 103 fever who's happy and playing and crawling around, who's sick? Yeah, so don't treat the fever. But you're saying, hey, Joan, that's only a 101. Doesn't matter. That kid is, you know, that kid is behaving sick. He gets treated. Treat him for comfort. You can bring the fever down a little bit. Kid with a 103, 103.6, he's running around, crawling around. You don't have to treat him. Remember what I said about prolonging illness by very aggressive management. So we're a little bit more calm, not cavalier, but, you know, in terms of our managing fever. We really don't put kids in the tub anymore. Unless you got to give, I shouldn't say this, the mother something to do in the middle of the night. You know, the point is you put him in the tub, the kid screams, what does he do? Generate heat, he gets cold, you pull him out of the tub, his fever goes back up. So it's not an effective management modality. The old cooling mattress in hospitals we really don't use anymore, okay? Because the kids go on that little cooling mattress and then they shiver or they crawl off into the corner, you know. It's not really effective. So the extraneous or environmental methodologies are really reserved for some very sick kids, and I'll give you those examples, okay? So the current recommendations really today, you manage a fever between 104 and 106, bring it down, let it hang out at 102, 101 where the kid's comfortable. We don't have to aggressively manage it and bring it back down to 98.6, you know? Pharmacologic management is the way to go. It's the only way to change the set point. The external cooling methods, this is you know, significant. That kid who's hyperthermic in the car, that kid you got to cool down, throw him in an ice bath, hose him down, do whatever you can. Because remember, Mother Nature's not in charge, you know, there. So this is kind of what we're doing in this day and age. Okay. The one thing, there's 2 times I'm going to tell you now to be a little bit concerned, and everything that I just said is not true. And it's this group. So the febrile infant, so this is really, we're talking about the first 6 to 8 weeks of life. You can extend it up to maybe 12 weeks, okay? That carries a different significance because for most of our children beyond this age group, the degree of fever does not equal the acuity of illness, right? We already talked about that. However, not true in the infant. The higher the temp, again, does equal the sicker the kid, especially our unimmunized babies, and they don't get immunized till 8 weeks of age. So that's something to file away. So it's maybe the first 8 to 12 weeks of life, we have a different respect, okay? The other group is children with underlying neurologic problems. All right, so let's take a kid who has a seizure disorder. All right, a kid with a known seizure disorder. That kid, well, no, maybe we won't do that. Let me get a kid who's got some neurologic, so-called cerebral palsy. All right, so let's take a kid, and we can't always make a determination that his central nervous system is functioning appropriately. So in this group, you might get called to a kid with a seizure who happens to have a fever, except the fever in this category of kid may act as a trigger, but it's not the true febrile seizure. So this kid has an alteration, say, in central nervous system functioning, so the fever itself can actually be a trigger. And it can actually be a trigger in a kid with a seizure disorder. All right, so remember there's a little bit of a difference there. So that kind of group carries a little bit of a, angst, along with that. So our febrile infants, especially unimmunized, it is significant. Higher than 10 does equal the degree of illness. And it's just that the risk of sepsis is very high in this particular age group. All right. So what do we want? Oh, that's it. Okay. All right, we'll go back to that. All right, so once again, the febrile seizure, considered a normal phenomenon of childhood, is relatively benign, zero mortality, with that even zero morbidity, no sequela. The neurologist doesn't see it, they don't do EEG, they don't do anything until the kid has had a second febrile seizure. The majority of the kids only have one in a lifetime. And you get to that third febrile seizure, then the neurologist is going to start thinking, going down a different pathway, that perhaps this kid is, and they're statistically significant, is going to develop a seizure disorder. So a true febrile seizure, there's some real distinctions. So I hope it kind of makes you feel just a little bit more comfortable in dealing with these kids. Remember, not cavalier, but a little more comfortable in knowing what you know about that pediatric population. You with me? You calm now? All right. Not going to get crazy like that mother? All right. Any questions?
So what did you do that night?
Nothing. What are you going to do?
You just talked to
There's no
her?
treat- yeah, she already had the Advil, so the kid had the, the kid got transported. I really wanted her to call a pediatrician, who'd probably say, because then the kid gets the ER, all with all the other dirty, sick kids and people, and gets sicker, but no. They'll evaluate that. Once they go to the ER, they get chest x-rays and all kinds of stuff.
Did she call the pediatrician?
No, she was just frantic, so, where's my shoes and my purse? And the other kid was upstairs, and my mother's on her way, and Murph goes, I got 6 kids, I'll stay till your mother gets here. It was like, woo, it was that flurry of activity. So that's why I thought in light of that, I said to Mira, it's such a great, a great call and something that you will see given now, because there's a lot of illness going around, to understand what the febrile seizure is all about, and what fever is all about. Remember, a very small percentage of the kids will seize. It's very frightening. We're not underestimating that. And you'll probably spend more time reassuring the parent, which we kind of tried to do, but she was kind of, Anything else? Yeah.
You made a comment something about our equipment is not properly designed for measuring temperature with babies or something.
Oh, we have which one? No, we have an electronic thermometer right now, and you couldn't get unless we did a rectal temp on this 1.5-year-old, who was in the car, transporting in the car seat. It would have been interesting for us to get one more test, and we were really not able to do it with what we had. I think we should opt for the thermal scanner, the temporal scanner, because that then measures the temperature of the blood at the temporal artery, which again is up close here, and it's not down there. Actually, there's a 3-hour lag time between what you would see up here, central nervous system temperature versus rectal temperatures. So there's a 3-hour lag time before your rectal temp matches what your temp up there is, which is considered poor, by many. Yeah.
If a child has a second febrile seizure, will it be the same temperature as the first attack?
No. Actually, you don't know. I mean, take a guess, maybe that's where their seizure threshold and the body temperature cross. I don't think we have documentation that'll, actually prove that, but it could be, wherever it was. I mean, that's actually a good point, good question, I don't know. Anything else?
Well, what do you use at the office to take?
Tim. Our ER in the city, we use thermoscans. So it just depends. And when we're monitoring it, I said it's just what's easy for us to do with the children, and then you kind of use the same technique. Yeah, I think they're really nice and easy now, even a little bit better. With the tympanic, the ear thermometer, you really have to have a good seal. When you press that button, it's rapid too. So, yeah. So remember, it's kind of like the zone. You kind of know where it is, and how was the kid. Big behavior. I'm a big behavior person. So kind of fun. So don't let it scare you too much. Okay. All right. Okay. You got it. Anybody who wants to stay, this is actually one section of an evaluation. You can do it tonight. Get snowed in.